Those with frozen shoulder present with shoulder pain and a progressive loss of both active and passive shoulder movement. It was originally believed that adhesions and inflammation of the shoulder capsule were sole contributors to this pain and loss of motion, hence its other name, adhesive capsulitis. Based on this assumption, treatment often involved aggressive, painful stretching and/or procedures in order to break up these adhesions. However, as more information has become available, our understanding of this condition and treatment options has evolved. In this video, I'm going to discuss what frozen shoulder is, how you diagnose it, expectations for recovery, and exercise and treatment options. What is frozen shoulder? Frozen shoulder is classified into two types. With primary frozen shoulder, the exact cause is unknown, and that is why it is often described as idiopathic. However, it is generally more prevalent in those who are 40 to 65 years old, female, and who previously had frozen shoulder on the opposite side. Secondary frozen shoulder can be associated with diabetes, thyroid disease, stroke, trauma, and various shoulder pathologies. Signs and symptoms related to frozen shoulder are often associated with inflammation, fibrosis, and contracture of the shoulder capsule and surrounding structures. However, a popular study by Holman and colleagues found that in 5 patients with frozen shoulder, passive shoulder range of motion significantly improved after the administration of general anesthesia. All 5 patients saw a significant increase in shoulder abduction, while 3 demonstrated an increase in external rotation. 1 patient even saw an increase up to 105 degrees of shoulder abduction and 41 degrees in shoulder external rotation. This tells us that frozen shoulder may not be solely as structural as once thought. Now, it still has an inflammation component and will present with capsular thickening and restrictions in adjacent tissues. This is especially true as immobilization progresses. But it's important to understand that muscle guarding and pain are likely major contributors to movement restrictions seen in some individuals with frozen shoulder. Diagnosis. Frozen shoulder will present with passive external rotation loss that is greater than 50% of the uninvolved shoulder or less than 30 degrees. This measurement is taken with the shoulder in neutral or arm at the side. Additionally, it will also have deficits in range of motion of greater than 25% in 2 other planes. For example, shoulder flexion and abduction may be limited by 25% compared to the other shoulder. It is worth noting that other conditions can present similarly. X-rays are not necessary, but can help rule in or out other conditions such as severe osteoarthritis or a dislocation. Clinical course and expectations. It has been proposed that frozen shoulder progresses through a self-limiting natural history of 3 separate stages. Each stage was named based on symptom presentation and provided a timeline. Freezing was termed the painful phase and lasted 10 to 36 weeks. Frozen was termed the stiffness phase and lasted 4 to 12 months. And thawing was termed the recovery phase and lasted anywhere from 5 to 24 months. However, there are 2 reasons why these might not be the most appropriate to use. The first is that it implies a natural history, meaning you would progress through these different phases over time, ultimately leading to a full recovery without treatment. However, in 2017, Wong and colleagues did a systematic review and found that there was in fact no evidence to support this theory. Furthermore, expectations of eventual thawing leading to complete recovery without treatment may lead patients to delay or forego treatment. And second, Hand and colleagues found that some patients reported mild or moderate and severe shoulder symptoms anywhere from 2 to 7 or more years after initial onset of frozen shoulder. This demonstrates how timelines may set a false expectation for the duration of symptoms. One of the most important aspects to understand is that progress and recovery will take time, as this is a slow-moving condition. If someone tells you they received a given treatment and it immediately fixed their frozen shoulder, they likely did not have frozen shoulder. So be very cautious about any claims that provide a quick fix. To be completely transparent, it is very challenging to provide you with a concrete timeline for recovery. But do understand that with time and effort, symptoms will improve and functional limitations will get better. Exercise guidelines. Exercises will be chosen based on your irritability levels. High irritability is generally characterized by high levels of pain, consistent night or resting pain, pain occurring before end ranges of shoulder movements, and active shoulder range of motion that is significantly less than passive range of motion secondary to pain. Moderate irritability is generally characterized by moderate levels of pain, intermittent night or resting pain, pain occurring at end ranges of shoulder movements, and active shoulder range of motion that is similar to passive range of motion. And low irritability is generally characterized by minimal levels of pain, no night or resting pain, pain occurring with overpressures into end ranges of shoulder movements, and active shoulder range of motion that is similar to passive range of motion. For each level, I will provide exercise options for improving shoulder range of motion, specifically for external rotation and flexion, thoracic mobility, since this can further help improve shoulder range of motion and function, and finally shoulder strength to help maximize outcomes and address another deficit commonly seen in frozen shoulder. Let's start with exercises for the high irritability level. Since pain is already very high, focus on performing exercises relatively pain-free or within comfort. Supine external rotation using a dowel. Lie on your back and place the involved shoulder at your side, supported on a towel or object for comfort, and your elbow bent to 90 degrees. Holding a stick or dowel, use the non-involved side to move your shoulder in and out of as much external rotation as tolerable. Supine shoulder flexion with a dowel. Lie on your back and hold a dowel or stick with both hands up toward the ceiling. Slowly move your arms overhead as far as tolerable, and then return to the start and repeat. For either of these options, use as much assistance from your uninvolved side as needed and perform for 2 to 3 sets of 10 to 15 repetitions 1 to 2 times a day, every day, or within tolerance. For thoracic mobility, here are 2 options, one for thoracic extension and one for rotation. Thoracic extension on a foam roller. Place a foam roller across your thoracic spine or middle back and support your head with your uninvolved side while crossing the involved shoulder over your chest. Extend your spine back as far as comfortable and then return to a flexed position. Repeat this motion of extension and flexion along multiple points of the thoracic spine. For rotation, you will perform a half kneeling rotation with arms across your chest. Rotate over the up knee, twisting through your middle and upper back. For either of these thoracic mobility exercises, perform for 2 to 3 sets of 10 to 12 repetitions 1 to 2 times a day, every day, or within tolerance. And finally, 3 options for shoulder strength. If you have high irritability, isometrics may be a good starting point since these will activate the muscles without moving the joint, allow you to self-select your level of intensity, and may even help reduce pain. Internal rotation. Stand in front of a door frame or another immovable object with your upper arm at your side, elbow bent to 90 degrees, and lower arm straight ahead. Press inward without moving your arm, shoulder, or body. For external rotation, the setup will be the same, except now you will press outward against the door frame or object. And finally, for abduction, stand with your involved shoulder next to a wall, elbow bent to 90 degrees, and lower arm straight ahead. Push your arm away from your body into the wall. For these, slowly ramp up to the highest intensity possible without pain and hold for a duration of 20 to 40 seconds. Perform 1 to 3 sets, 1 to 2 times a day, every day, or within tolerance. If you have moderate irritability, keep pain tolerable during exercise and make sure you do not have an increase in symptoms the next day. Continue the previous exercises, or if tolerated, here are some progressions. Active supine external rotation. Lie on your back with your arms supported at your side and actively rotate your arm outward, keeping your elbow bent to 90 degrees. Move in and out of a tolerable end range. As your motion improves, perform the same movement but with your arm further away from your body, working up to 90 degrees of shoulder abduction. Supine shoulder flexion with a weighted dowel. If tolerated, add a weight to the dowel, even as little as 1 pound, and perform the same pullover as previously described. The added weight should help move your shoulder further overhead. For either of these options, perform for 2 to 3 sets of 10 to 15 repetitions, 1 to 2 times a day, every day, or with intolerance. For thoracic extension and rotation, you will either continue with the same variations mentioned previously, or if tolerated, you will manipulate arm placement. For thoracic extension, you will now place both arms behind the head as you move in and out of extension over a foam roller. While for thoracic rotation, you will now keep the arm straight as you rotate, reaching the arm as far back as you can. Perform for 2 to 3 sets of 10 to 12 repetitions, 1 to 2 times a day, every day, or with intolerance. And finally, shoulder strength exercises will progress from isometrics to isotonics, or in other words, moving through your full available range of motion against resistance. Banded internal rotation. With the elbow bent to 90 degrees, place a towel under the arm to help maintain a neutral shoulder position. Holding a band, rotate inward towards your stomach, and then slowly control back to the start. Banded external rotation will be set up in a similar position, but you will now rotate outward. Throughout the entire motion, try and keep your elbow bent to 90 degrees. And for shoulder abduction, you will perform a single arm lateral raise with a band. Stand on a band to anchor it, and then raise your arm outward to about shoulder height. 2 suggestions if you find these uncomfortable. First, you can lift the arm in scaption. This is not directly at your side or in front of you, but instead the motion is in between. And second, you can perform a lateral raise, but reduce the range of motion to below shoulder height. For banded shoulder strength exercises, you will perform 2 to 4 sets of 10 to 15 challenging repetitions at a controlled speed every other day. And lastly, for low irritability, follow the same previous pain parameters. You can continue with the previous exercises or progress to these options if tolerated. Weighted supine external rotation. Hold a weight, even as little as 1 pound, and rotate your arm outward. Start with your arm at your side, and as your motion improves, move your arm further away from your body, working up to 90 degrees of shoulder abduction. Weighted single arm pullover. Keep your elbow straight and low back flat to the floor, while you pull a weight overhead as far as comfortable. As range of motion improves, you can progress by performing on a bench or elevated surface. Perform these for 2 to 3 sets of 10 to 15 repetitions every other day or as needed. Half kneeling thoracic windmill. Rotate over the up knee, trying to make a big circle with the arm as you rotate through the spine. Throughout the movement, keep your eyes on the moving hand, as this will help maximize thoracic rotation. Perform 2 to 3 sets of 10 to 12 repetitions each side every other day or as needed. And for shoulder strengthening exercises, continue with banded internal and external rotation and progress banded abduction to 120 degrees if tolerance allows. Perform these for 2 to 4 sets of 10 to 15 challenging repetitions at a controlled speed every other day. Other exercises and lifestyle factors. In addition to these exercises, regardless of your level of irritability, walking and participating in other forms of tolerable exercises is highly encouraged. For example, if you can tolerate push-ups, rows, squats, deadlifts, etc., continue to perform those as programmed. As well, properly managing other lifestyle factors such as stress, sleep, and nutrition are really important considerations, since these can all have a profound impact on your symptoms and recovery. Load management and activity modifications. Consider manipulating the intensity, volume, and/or frequency of your desired activity so that you are able to make it more tolerable. For example, if you enjoy playing tennis or golf, you may need to reduce how often or how much you play. In some cases, especially with higher levels of irritability, You may even need to temporarily stop activity and reintroduce it later as irritability improves. But this does not mean stop everything. You may consider substituting it for other forms of activity such as biking, running, resistance training, etc. Other treatment options. The UK frozen shoulder trials found that after 12 months, manipulation under anesthesia, articular capsular release, and physiotherapy plus steroid injection all led to superior improvements, but neither of the three were clinically superior. Chalomas and colleagues found intra-articular corticosteroid injections to be helpful in the short term when compared to other non-exercise-based treatments. Additionally, a home exercise program was clinically significant compared to no treatment. A 2019 systematic review compared different pharmacological interventions and found intra-articular corticosteroids to provide clinically meaningful improvements in the short term. A study from Cho et al. Concluded that steroid injections can be helpful for pain management in the short term, but showed no differences between control groups in the long term. Kral and colleagues did a scoping review on the pathophysiology of frozen shoulder, and their results help explain why intra-articular corticosteroid injections should be used early on in the condition and why the intensity of physiotherapy should be guided by tissue irritability. And finally, Kelly et al. Found corticosteroid injections led to an immediate significant improvement in shoulder range of motion, implicating pain and muscle guarding as opposed to fibrosis or adhesions as the initial barrier to joint motion. Alright, so I know that was a lot of information, so let me summarize. Frozen shoulder will present with shoulder pain and a progressive loss of both active and passive shoulder movement, most notably a loss of passive external rotation greater than 50% of the uninvolved shoulder, or less than 30 degrees, and deficits in range of motion of greater than 25% in two other planes. While inflammation, capsular thickening, and restrictions in adjacent tissues play a role in symptoms and presentation, you also need to strongly consider muscle guarding and pain as major contributors to movement deficits. This is why choosing exercises and treatment based on your shoulder's irritability levels can be helpful guidelines to follow. When irritability is higher, focus on performing relatively pain-free shoulder and thoracic range of motion exercises and shoulder isometrics. Since pain may limit activities, strongly consider walking more and implementing strategies to reduce stress. In addition, corticosteroid injections may provide short-term benefits since they can help dampen the inflammatory response and reduce pain. As irritability moves from high to moderate to low, progress exercises by adding weight and increasing the range of motion you move through. Keep pain tolerable during exercise, about a 3 out of 10 or less, and make sure you do not have an increase in symptoms the next day. In addition to these options, you may also want to consider other range of motion and strengthening exercises depending on your restrictions, goals, etc. And finally, understanding the clinical course of frozen shoulder helps set realistic expectations. Time frame is extremely variable and not quite as predictable. Rather, focus on making objective progress over the period of weeks to months. Can you reach your arm further overhead? Are you able to increase the reps or weight with different exercises? Pain and function will eventually improve, but this process will take time, effort, and consistency. Alright, that is it for today's video. Do us a favor, tap that like button, subscribe, and even turn on notifications. If you have any questions or comments, just drop those down below. Until next time.